That's a very good comment. Excellent presentation. Now I call upon Dr. Mallika Harikrishnan to talk on the mistakes we make on optic disc examination.
Very good morning to you all. Thank you KSOS for this opportunity. I would like to talk on optic disc, the mistakes we make. Optic disc evaluation provides valuable structural information about the optic nerve damage and its progression. And glaucomatous changes, as you know, in optic nerve head and RNFL may precede defects detected by standard automated perimetry. So we'll go by one the mistakes. Mistake number one, faulty examination techniques. What is the ideal method? Is it the indirect ophthalmoscope? No, because it gives a minified view. Is it the direct ophthalmoscope? Until you are in a screening, as a part of your screening, it's okay. Otherwise, it's not, because it's a monocular vision. And undilated fundus examination? No. So what is ideal? Slit lamp biomicroscopy with 60, 78D or 90D. And mistake number two, you rely only on CDR for diagnosis. You know that 1.2 million axons pass through each disc, but the disc size varies. Think of the leftover space. The space varies with the size of the disc. In the small size, the disc size, the cup will be smaller. Medium disc, the cup will be medium, and the large disc, it is large. So it varies with the size of the disc. What is important is the documented increase in the CDR, cup disc ratio, over time. That is a sign of glaucoma. Mistake number three, you take rigid decision with IC rule. I know that IC rule is very important as a diagnostic part of glaucoma, but what is important, what you have to understand, it is variable, and it also more with the large disc, less with the smaller disc, and there is more reserve in the large disc. The IC specificity in Caucasian eyes, it is 85 to 90 percentage, where in Indian eyes it is only 65 to 70 percentage. Just I would like to share an experience. This is the disc of a 12-year-old boy came to the OP with a history of headache. The disc shows very alarming. And we subjected the patient for all these sophisticated investigations, but nothing was found. Finally, we examined the fundus of his father. See, just it is almost similar. So you have to make, as a part of your examination, examine the family member. Maybe they will have a familial type, but you have to take all these things into consideration. That is my message. So mistake number four, too much importance to parapapillary atrophy. As you know, beta zone is more important as far as glaucoma is concerned, which indicates the atrophy of the RP and the choriocapillaries. But it is, what you have to understand, it is not specific or sensitive enough to be important. What is important is always look for whether a new beta zone is appearing or is there any enlargement of the beta zone. Number six, not looking with the red-free photograph. That is a very bad mistake, because for the beginners to detect the RNFL defect is with the fundus photo or fundus examination will be a little difficult. So as you see in the picture, it will be difficult here, but for the expert it is easy. But if you look at carefully, you can see a superior notch, but when you examine under the red-free light, you can see the RNFL defect, wedge-shaped RNFL defect. So suppose it is a patient with so much of tessellated fundus, it is even more difficult. But if you look at carefully, you can see the superior notch here, and you can correlate it with the field. You can see the corresponding field defect inferiorly. Mistake number six, differentiating with the myopic disc and tilted disc. That is the most important thing. It is very difficult because the myopes have a large disc, shallow cup, tilted often, and the fibers are stretched. Temporal displacement or convergence of the vessels will be there. False inferior and nasal thinning will be there. You should always have a high index of suspicion. So one important point I can point is that go largely by the contour cupping rather than a color cupping. And this thinning, notching, everything is masked because of the parapapillary atrophy also. Another important point you can follow is that use a 2 mirror with a coupling fluid and use the central lens that can differentiate the notch better. And another important thing is you can apply Joe's rule. I will come to that. And always important is that look for the family history or look for the progression. Joe's rule says that unless and until proved, you have to consider all this have glaucomatous changes. All glaucomas have RNFL defects. All glaucomas have disc hemorrhages, and all myopes have glaucoma, unless otherwise proved. And tilted disc may be glaucomatous, that may be familial, and it can be of high risk also. It may be congenital or associated with myopic tilted disc, may have no field defect, but they can have field defect as well, as you see in this picture, but that field defects remain stable. And what you can do is you can treat the patient if the IOP is high, and you can also consider the family history and always look for the progression as per the field effects. Mistake number 7, differentiating with a neurological disc. What is this disc? It's very obvious. Neurological disc. Pallor out of proportion to cupping. That's a sign of neurological disc. So you can see the field also, you can correlate that it corresponds to, it respect the vertical meridian. But what about this cup? There is a diffuse pallor, but here cup is more. It's more of a glaucomatous cup. What is this disc? Here you can look for the location of the kinking vessel. Here the cup is more. Cup is more than the pallor. This is also a glaucomatous cup. But what is here? What is seen is the disc is very small, but it is paler. Cups are shallower. CD ratio is smaller. This can be more likely an acute congestive glaucoma. So in short, if the cup is equal to pallor, that is normal. If the pallor is more cup, it is a neurological disorder or a glaucoma with very high IOP. If the cup is more than pallor, it may be glaucoma or maybe it may be normal. Number 8, disc with myelinated nerve fibers. So here, follow the disc where the myelinated nerve fibers start from and assess the NRR at that level and compare with the other part of the disc. But suppose the disc is all around, it is covered by the myelinated nerve fiber. There is no alternative. Glaucoma management is based on the IOP and the pachymetry. And the field also, it may or may not be reliable. OCT is not at all reliable. So to conclude, optic disc evaluation remains one of the vital diagnostic tools in the management of glaucoma. Mistakes can be minimized by the systemic evaluation techniques and serial documentation and correlating well with the OCT and the HFA findings. And after hearing my talk, if you see a disc like this and you feel the this call alarming sign, save me please. I am very thankful to you. Thank you so much.
Thank you, Dr. Mallika, for that excellent presentation.